Hello, lab experts. Welcome to the RoK Diagnostics podcast, the podcast where we discuss everything medical laboratory science in Africa and around the world. Today, we're going to be doing part two of our interview with David McGlasson. The last time we talked about nurse Genene Jones, we talked about the death shift, we talked about how he was able to help investigators determine how she was killing children in hospitals in Texas. Today we'll try and go into some slightly more details, ask some questions about the case, ask some questions about how he got to the conclusions that he did, and we'll also talk a little bit about medical overdoses and possibly what are some of the solutions that could be put in place to help reduce those errors in the medical field. So without much further ado, let's talk MedLab. We have with us David McGlasson, medical laboratory scientist, semi-retired with 50 years of experience. So, David, any opening words?
Yes, sir. It's good to be back. It was a very good experience last time, and I was pleased that, in fact, I just checked my LinkedIn website, and we got 500 hits exactly just a few minutes ago on there. And so that's I was very glad to see that that people had an interest in what we had to say about last time. We got kind of cut off in the middle. And I know that you guys had some questions that you wanted to ask. So, you want to take those first before we start discussing the case further?
Yeah, there was definitely a lot of interest from what we saw. When discussing the case, eventually, there was a part of the interview wherein you talked about investigations into medical personnel, like extra investigations. Did that actually happen?
Yes. Let me run down a brief scenario on some things that happened and what happened to some of the people in the case. We talked about how some of the nurses were starting to suspect Genene, and they would go to their supervisors to give their concerns, and they were being ignored. For example, one of the nurses started, her name was Suzanne Maldonado. Now, this is in the book, The Death Shift, as well as another book called Deadly Medicine. And she started getting evidence. She proved the kids were dying on Genene's watch. She gave the evidence to nursing supervisor Pat Belko, and the doctor who was supervising the ICU, Dr. Robotham. And Robotham started an investigation. He was worried about heparin, and he took concerns to his boss, Dr. Franks, who basically the hospital nursing supervisors and the physicians and the hospital administrator kind of blew them off. And it was getting to be a little bit bad. Another case that I had worked up for the heparin was a child who we found that Jones gave 333 times the dose to clear a line on a child. Bam, 2,000 unit per ml, 10 mLs right into an IV line. And that caused him to start having these mysterious bleedings. The first child that we worked up for, we found the heparin, had 4 incidences of unexplained bleedings, and until we were able to isolate that it was heparin. I know Dr. Cipriani, who you and I were talking about earlier, caught this nurse pushing glucose on a child that didn't need it without getting any lab tests. And we found that was the one where the glucose level was over 500. And, definitely a critical value on anybody, much less a small child. The hospital administrator had this vision. He wanted to wind up being Surgeon General of the United States, and he just ignored basically what was going on. The assistant administrator, who wound up being in charge when we went to trial and everything, person I knew very well, Mr. John Guest, really was disturbed about all these things and started asking questions of other personnel. And he said he discussed with Dr. Robotham about control of the problem. And also there were unit clerks who were reporting that supplies were missing. bottles of heparin, syringes, gauze, things that should have been there that weren't there. A nurse named Pat Alberti suspected Jones and made it a point to take care of Jones's patients when she wasn't there to make sure that nothing happened about it. She complained endlessly about the issue of malpractice going on, but basically told to be quiet about it, and that it was all misunderstandings. And finally, other nursing personnel were threatening to call a local newspaper columnist about the problem. And in fact, it was so bad that a couple of the nurses were so distressed about it, they actually sought psychiatric help because they were so disturbed nobody was paying attention to it. We talked the last time about one of the patients had an elevated Dilantin level, and it went from about 14 up to about 60. And my techs picked that up immediately, did the critical value checks, phoned it in, and nobody could figure out why, because that child wasn't getting Dilantin.
Yeah.
Later, I think I told
one
you
question.
that. Yeah.
How were they able to pick up on the Dilantin levels? Like, were there specific tests asked, or what happened exactly?
Right. They asked for a test on the child because they could not explain the seizures that were happening. And they said, well, the child is supposed to be getting some kind of seizure medication, but they weren't really sure what. So they went ahead and ordered the Dilantin level. And then that's when they found out that the levels were he'd been given a small dose earlier to start him, but he wasn't responding like he was supposed to. And the level went from, I think, about 14, and it was at 60 when we detected it in the laboratory. And we have the laboratory where we were still have this policy. You make your dilution, you have somebody, you calculate out, like if you made a 1 to 4 dilution, you check your work, see what comes out. Say if it comes out 14, then you would, or 15, take it times 4, it would be 60. You have somebody check your calculation. Then you phone it in to the floor. You tell the floor, this is our value. Who am I talking to? The time you put it in, you put all that in the computer. And so, interestingly enough, that was all still a part of the medical record. When I looked over this stuff back last year, it was all, like I said, it was still part of the medical records. And I recognized the names on them. I think I told you, the fellow who found that one is now an oral surgeon. His father was actually a pathologist. And another interesting thing about George, he was a member of the modern pentathlon team that in the Olympics. So he was quite a well-rounded individual. One of the other techs that found a drastically elevated glucose also is now Dr. Peter Ramirez, who is a clinical pathologist who went from being a laboratorian, went back to medical school and stuff. So I had really good people working with me on these shifts. And, like I said, most of these guys were in school doing something, and that's why they were working part-time with me on these 3 to 11 shifts, picking this stuff up. But like I said, the boy who's now, 36 years old, who I found the original issue with on heparin with the multiple bleeding episodes, he is now a 36-year-old man. Yeah. He claims he can still see the spot on his arm where Genene injected him. And I said, well, it may or may not be true, but he believes it. He's alive. He's happy that we were able to find it. What was interesting, though, was one of the physician that had the child that was bleeding took him out of the ICU, and all his problems resolved within 5 days once they got him away from that nurse.
Yeah.
Now, the nurse administrator said, the bottles were confused with amoxicillin. So, they were different labels and different size bottles, but that was the excuse she gave. Everybody just seemed to want to cover it up. And I think I mentioned last time that the lawyers with the hospital district were consulted about this, and they just basically said, well, if we blame her, we can have a lawsuit and, stuff, and we don't have definite proof, even though they had a mountain of it. Like I said, CDC was eventually called in on it to evaluate this problem. But the way they got around it was they took all of the LVNs out of the ICU and only RNs could work there. So that was the way they solved it. What the committee was formed, and what they discussed was they dismissed the notion that one nurse was killing the kids. They looked at the PDICU as a whole problem, so they overhauled the whole unit, like I said. Dr. Robotham took the hit. He was let go. The nursing supervisors covered up saying enough was not documented, so they couldn't fire anyone. And they were afraid that if they just fired her, she would have a lawsuit. And actually, Genene left a death threat message for Susanna Maldonado, the nurse who started it all. And it was turned over to nursing administration. They did nothing after saying they would handle the matter internally. Now, the hospital didn't pass this information on to prospective employers because they were still afraid that she would be suing them. And so they gave her a warm endorsement, and she went with Dr. Kathy Holland up to Kerrville, Texas, and the death started again. Up there, she used succinylcholine, which is the purified equivalent of curare. Curare is a very old drug. Indigenous people in South America actually used to put it on their darts and poison darts to bring down game with it. In medicine, it's used as a paralytic, especially of the respiratory system when they're intubating somebody who's fighting the intubation, especially children. So that way they could, so they can intubate them easily without tearing up the airway.
Yeah.
So up there is when she got, like I said, really creative, and the deaths started again. Now, this is after 47 suspected deaths in San Antonio. This former resident, Dr. Holland, who had gotten a good endorsement from the hospital on Genene, just wasn't aware of what was going on. So what we had then was a situation, you had a nurse that had already been involved in all these deaths, went to another town, another clinic, and other hospitals were involved up there, and had the problem starting all over again. Yeah. The investigation by the DA office from February of '83 to October of '84, what they did, they were thinking about exhuming 23 bodies, and 2 were exhumed, and they took tissues from them, and they had tissue blocks from samples that were taken before, and they started looking at them, and this fellow developed this technique for detecting succinylcholine in paraffin blocks from histo stuff. In the Bexar County investigation, the drugs that were suspected were Dilantin, heparin, digoxin, and also succinylcholine here. They looked at, we talked earlier about the children that Joshua Sawyer was the one where we had the unexplained Dilantin, Rolando Santos, and these are all names that have been put in the media. They've been on TV. They've been in multiple books. So I'm not conveying anyone's private information on this because it's already been vetted numerous times in open court, everything like that. So, but it was very interesting. She was first tried up in Kerrville, Texas, for the death of one Patty McClellan, and that was the one where they got her on the succinylcholine. She got a life sentence up there.
Yeah.
And then they brought her back to San Antonio and tried her on the heparin overdose. And what they got her for here was for criminal abuse of a child, and they gave her 60 years. The judge in San Antonio, the judges decided to have the sentences served concurrently, which if they just said they had to be done consecutively, she wouldn't have had the problem of possibly getting out.
Mm-hmm.
And at that time, I think I mentioned last time, Texas had these very bizarre sentencing laws that gave 2 for 1. If you had a good day, you got 1 day off in the sentence, and that's why she was going to get out after about 35 years, which was in 2019. And so it became a problem, and the uproar in the community of people that were still around, both by medical personnel and by people who were still, who had lost children, or like Mr. Santos, who was still alive. They're going, we want her tried again. So they're going to try her on 4 other cases. Now, the drug succinylcholine, actually, there were a couple of books written, one by a very famous author named John D. MacDonald, who normally wrote fiction, but he wrote a book about called No Deadly Drug back in 1968, about a doctor whose wife died unexpectedly, and they never could explain what's happening. Succinylcholine disappears very rapidly in the detection system. And this guy killed his wife. His name was Dr. Carl Coppolino, Coppolino. He can be looked up. His first initials were CA, and his last name was Coppolino. And in 1980, a book was written about him also called The Crime That Never Was. Not only did he kill his wife, he then killed his lover's husband by injecting him with succinylcholine. And so, he had, in fact, you remember the O.J. Simpson murder case?
Yeah.
Okay, big deal, several years ago.
Mm-hmm.
One of his lawyers, F. Lee Bailey, made his name defending Coppolino on these charges. Yeah, that was just something I just remembered. But what they finally did on him, they did detect in the brain tissue by a New York toxicology lab of this victim later in 1980 was succinylcholine in the brain tissue by doing it in the paraffin section. So that's what they went after in the McClellan case up in Kerrville. And it was a couple of PhDs, Readers and Olmsted from, I think one of them was from Sweden and the other one was from the United States. They looked back on him and looked back on the tissues and were able to reproduce that work. And I think that they found it in, they did it in thigh muscle, both the left and right thigh. They found it in gallbladder tissue and in the liver, in formalin-fixed tissue. Now, this isn't the first time, there's been medical personnel, in particular, nurses seem to be the ones that are the most prolific when it comes to hurting patients. Don't know why. I guess it's just because they're the ones that have the most contact.
Yeah.
But there was another case of succinal homicide by one they called the Angel of Death. His name is Efren Saldivar, back in hospitals in Glendale, California, in 89 through 1997. He killed maybe between 40 and 50 patients by using succinylcholine and something called ancuronium, which was detected in 6 of the exhumed cases.
Yeah.
Pancuronium is something they use in lethal injections to kill people in capital murder cases, to execute them.
So in the case of the Angel of Death, he was using succinylcholine. Now, one thing with Genene, it seems she used lots of different things like glucose, calcium, Dilantin, succinyl.
She liked to create situations where she could get involved and correct the situation because she knew what was going on.
All right.
Sometimes she went too far. Sometimes she went too far on purpose. Other times she was like I think I mentioned last time, Dr. Debbie Rash, who I became very close to over the years. In fact, she took care of one of my children. I think I mentioned last time when one of my children were in that PDICU later. She took care of him for a severe upper respiratory issue, and but she caught her injecting calcium, which would have induced a seizure in this kid. And the kid, the calcium wasn't on the formulary for this child. Dr. Cipriani caught her injecting glucose at a time. And then when the child got the overdose of Dilantin, that was done with a bolus of glucose on top of it. So, you got a lot of issues there.
Did she ever try to do anything to adults too, or was it only children?
She came to that hospital after abusing a patient, an adult patient, in another system, another hospital system. It was the Methodist system. Now it's still called Methodist here locally, but I think it's part of HCA in the United States, Hospital Corporation of America. So, you know, there's always been this problem with her in various places, and it just seems to get swept under the rug. In Kerrville, they took it very seriously. That's a small town in comparison to San Antonio, probably about 40,000 people, but they have a large VA hospital there, and they have Sid Peterson Hospital, which is a very well-respected mid-sized hospital in the area, and it's one that takes care of patients in about a 50-mile radius. So the hospital committee up there started telling Dr. Holland, you got a lot of kids dying out of your clinic and stuff. And she goes, yeah, well, I'm taking the sickest kids on, you know, not realizing that she had this angel of death also working for her. So that's when the suspicion started up there again. Then that got back to San Antonio, and the DAs in both places started conferring back and forth with one another. And that's what, you know, helped bring her to the two trials that they did. You know, yeah. And they actually, on the succinyl homicide, I've got a quote here. This was an expert witness in the Copolino case that I just mentioned, the one that killed his wife and then his lover's husband. The person said, if you want to kill a person, get away with it. This is really a good drug to use. So when he was talking about the succinyl homicides, and that kind of, you know, made him really taking a good look at it. The key thing is, in all these cases, the medical lab was involved. You had personnel there that were able to recognize what the issues were. It gave the physician the best numbers to go back and treat the patients with. Unfortunately, we had this evil presence working outside of us that were causing all the problems. But think about this, one LVN almost crashed two hospital systems, caused untold damage to as many, they think, as possibly 60 families and innocent children. And it's just unfathomable to me how this happened. But the fact that personnel were in place, and back, I don't know if you can see this book, it's a little bit old here. It's called The Death Shift. Mm-hmm. That's a picture of Genene on the front, and it's written by Peter Elkind. Okay. You can look him up online, and he actually does a podcast himself. And I talked to him last year about this, because one of the things, I've had to deal with the press on many occasions, and they rarely ever get it 100% right. And I'll give you an example. My specialty, of course, is blood coagulation, but I was working with brown recluse spider venom. Brown recluse spiders are endemic to the Southwest and warm, dry regions down into Mexico and actually into Central America. It's their genus and species name is Loxosceles reclusa. And it means, they hide. They hide in like abandoned wood piles and old sheds and attics. God help him, a friend of mine that I was in the Army with, he taught hematology and I was in microbiology at the time, Bill Fetter, who became a neuropsychologist, in fact, worked with astronauts at the NASA Space Center. When he moved into a new house, he saw a little cobweb in the corner of a room, and he just happened to nudge it with his bare toe. A brown recluse spider bit him. He didn't even feel the bite. He wound up losing his entire leg. Yeah, it causes a tremendous necrotizing fasciitis, and also the bite is kind of dirty, so it also can get a MRSA infection, a MRSA staph infection. And well, what I had done was I'd found that I'd read a book, and I had a physician working with me who was a resident at the time, who was also had a PhD in toxicology, Dr. James Babcock. He comes up to me and he says, "Hey, I've got this spider venom that does some weird things when you put it in plasma. You want to play with it?" And I said, "Sure." And he had written a paper saying that it reduced coagulation factor 8 and 9s in human plasma when it was in vitro. And I said, "Oh, okay, let's look at it." So I verified that, but I also looked at all the coagulation factors 2 through 12, and of course, factors 2, 5, 7, and 10. Also, 10 can be assayed by a PT or a PTT, and the 8, 9, 11, and 12, of course, are the intrinsic pathway. Those are assayed usually by a PTT. This is the one-stage coagulation factor assays. But what I found was Babcock was right. It reduced them, but when you diluted it out, it looked like a lupus anticoagulant and corrected. Now, this was very unreal, and I'm going, wow. Now, why doesn't it do that on the extrinsic pathway ones, the 2, 5, and the 7? And the 10, if you did it by a PT method, which is the way you normally do it, but you can do a 10 by a PTT method. And what it did on all of the extrinsic ones, or rather, it did not cause this dilution. It did not have this decreasing of the factors at all. They stayed the same. But on the intrinsic phase, they reduced. Like when you went from 1 to 10, 20, it went down, it decreased. When you went out to 40 and 80, it started coming back up and normalizing.
Right.
And what's the difference in that? You know what the difference is? The reagent. PT reagent has about 200 times more phospholipid in it than the PTT reagent. So it overcame the lupus anticoagulant effect that occurs. And that's one way that you can pick up the term lupus anticoagulant. I said, hey, you know what we've got here? We've got a control plasma. And so I named it something called Arachnase. And, after arachnid spiders. And so that's what we called it. And we had some fun with that. The problem was I couldn't make a recombinant of it. It ate through everything that we put it into. You normally put it into a lipopolysaccharide or something like E. coli, and it just ate through the shells. It's really toxic stuff. In fact, I just sent some, since that happened, and this is what is really cool about scientific research. From that point, Dr. Babcock, and then initially he had to write it. We wrote another paper saying we were wrong. It does not really reduce 8 and 9. It decreases it and then corrects upon dilution with a lupus anticoagulant effect. So we then, did some work with this. We found out we couldn't make a recombinant. And we also found out that it worked primarily with PGT reagents that had sphingomyelin in them. And the brown recluse venom has a anti-sphingomyelinase D property to it. It just literally, that's what happens when it gets on, like you get a bite on your hand or your arm, it starts eating the myelin fibers up, and it causes a real bad lesion, or what they call an eschar. And, then you can get, it can get into the bloodstream. You have terrible infections. It just literally rots the skin off. That's what happened to my friend, unfortunately, God rest his soul. But from that work, I was contacted by people at the University of Missouri, and also at Michigan State, and a private doctor clinic called a company called Spider Tech, and also by a company out in Arizona called Spider Farm. And they're in fact selling some of this stuff now. But Dr. Babcock and I went out and we caught 400 brown recluse spiders because the venom is very expensive. We used to buy it from a company called Sigma. I don't even know if they're still in business anymore, but it would, like for 5 micrograms, it was $175. Well, how this has led to it? Yeah.
How did you catch them?
Yeah. We scooped them up in little plastic, what we used to call Coulter vials. Little vials you have in the plastic with a white snap lid on them. Mm-hmm. And then we took them back and we froze them.
I guess you had to wear some really heavy gloves.
Yeah, you made sure that you did. Yeah, the bite, is really guys out in the field here, like GIs and stuff. What they're taught is to when you get up in the morning, tap your shoes and shake them out to make sure that the spiders haven't crawled in them at night.
Yeah.
Let me finish this one story, and I'll tell you how the brown recluse ended up in Iraq. Never been there before, but. What we got from this is we did some other papers we developed a method for detecting the brown recluse bite because it looks like a number of things. It even can look like a herpes or a shingle infection. It looks like a MRSA bite. So what we did was we developed a swab technique, and we also found that DNA swabs aren't good for it. The regular cotton swab causes less absorption, and we were able to, like if Robertson or Wisdom gets bit by a brown recluse, we can swab their hand, the lesion is there, and we can pick up out to 21 days the antibodies that bite makes. Yeah. And that is something that was really cool. Now that's been developed into a test kit. We've made it what they call laboratory developed test, and now we can tell within an hour whether someone's had a brown recluse bite. And that can be in any emergency room and done by an ELISA method. Yeah. And we're actually working on a new color change method, much like a pregnancy test, for it. Like I said, that all started from just a guy coming in saying, "Hey, I've got some funny stuff here. You want to take a look at it?" And we were able to trace it all the way down. And now every hospital in the country can. Within an hour, check and see if that's really a brown recluse bite because it can go very fast. A good friend of mine actually was the first person ever treated for a brown recluse bite in Paris. He worked at the time for Diagnostics Stago. And when he was in St. Louis, he noticed that he had a small lesion on his finger. And he goes, "Wow, what the heck is that? I must have gotten bit by something." He got on a plane, went to France. By the time he got there, it was all the way up his arm, red streaks, and the lesion had gotten bigger. Yeah. And he was hospitalized in Paris, and I know several of those guys. And Jim was written up as the first brown recluse envenomation ever in France that they know of. Now, through the military, during the Iraqi war, of course, we were shipping all kinds of equipment and supplies and people from Fort Hood and Fort Sam Houston here in Texas and other Texas bases over to Iraq. My commander at the time at the 59th Clinical Research Division Colonel Azzi, he's an entomologist, study of bugs and stuff. That was his thing. And they sent him to Iraq because they said, we're either having really bad staph infections over here or something is here that's causing our troops to be bitten. And Jim was able to isolate and find brown recluse in Iraq. They'd never been there before. But because we shipped stuff over from here, they were hiding in the equipment in dark places and stuff. And they wound up over there. So from Genene, from heparin to brown recluse spider venom, it's amazing how things all kind of get tied together.
Yeah, everything comes together.
My experiences with heparin back then, with protein sulfate titrations, then led to what we've got now, the anti-10A test for monitoring heparin, both low molecular weight and unfractionated. Mm-hmm. And then I got into, we need to be able to find out what type of heparin we're dealing with, or we don't have to worry about it. It's on the unit, because there was a lecture that someone gave here on a podcast on the network here a few months ago. It talked about one of the problems that they had in the lab. They always had to call to find out what type of heparin it was on, even if they were using the hybrid curve that I developed that could test any of the heparins with the exception of fondaparinux or Rixtra, because it's kind of like a heparin, but it's not really, and it has a really low molecular weight to it. Mm-hmm. But, so then we've got a single hybrid curve now, where if we get a request for an anti-10A, we can just run it if it's a heparinoid. Actually, that anti-10A test also can be used for monitoring the direct oral anticoagulants if you have the calibrators for it, such as Xarelto, Eliquis, which are rivaroxaban and apixaban together. So, got any questions, guys?
Uh, okay, I had a second question that you covered during our discussion. I just wanted to know, why do you think most hospitals, or probably most of the big hospitals, would prefer to cover up such medical errors that could also be murders in a way if investigated? Why do you think they would want to cover up such situations? Would it be a detriment to their reputation, or
Yeah, absolutely.
Yeah.
I mean, I don't understand why they do it. I would want to get to the bottom of it, but you have to understand the personalities involved of administrators and stuff. They don't want anything to come down bad that would reflect on the hospital, that would bring in investigations that might pick up something else. To me, I would have welcomed, something rather than having, more people, more children be harmed. I would want to know what was going on and get rid of that cancer. And to me, I would turn that into a positive. I would say, we saw a problem, we went after it, and we shut it down before it became worse. I mean,
Exactly.
There are things that happen in places. There are accidents, but, that's why you've got QA and QC people to pick up these things. You've got committees that study these type of things. You've got, if someone dies and there's not an explanation for it, most people, they have what they call morbidity and mortality conferences, committees to examine these things. And at the time, the wrong people were in charge. In fact, it was very interesting. At the end of Genene's trial here in San Antonio, the DA called Mr. John Guest, who was now the administrator of the hospital. And he said, "John, we just gave her 60 years. Now, I think you need to go to your staff and do what a man's got to do." And everybody that covered her up, he asked for their letter of resignation and fired them on the spot. So they took care of that issue, but they waited too long. And let's face it, you still got to prove it. You just can't make an accusation and stuff, but you got to prove it. And unfortunately, you had this maniac running amok on the unit, and you couldn't actually pin it down. But they should have listened to the people, before it. I've had one other time in my career where I knew someone was faking results, doing what we used to call sync testing. And I don't know whether you ever heard that term, throw it in the sink instead of testing it and act like you did it. And we had to get proof. I was a supervisor on, and man, they start coming after you. I told you what it was like during the trial and leading up to it, where they used people that I knew trying to get grand jury testimony and things like that. So, you have to have, like I said, you've got to have proof of it. But, they had people that, to me, had a mountain of evidence, and they just kept trying to look past the mountain on the other side rather than taking care of the problem, because they were worried about reflecting on them. And, a hospital administrator that has a murderer working for them doesn't want that out, but you got to do it. To me, it says more to the integrity of the person if they face up to it, especially medical personnel. I mean, you've got to, I can honestly say, I don't think and in my heart and in my mind, I never turned out a number that I didn't think was the best number that I could give to a researcher or a clinician in order to give that person on the other end of that specimen a good chance. If I did, it was an honest error, but in my heart, if I ever saw something that said this isn't right, I went back and repeated it. I figured out what was wrong and went from there. In fact, there is something that I posted online. It's called Laboratorian's Creed. In fact, I've got a picture of it, Robertson. I'll send it to you right after this is over, and you might want to post it. It was written by, when I first started in the profession, there were not degree programs in the medical lab sciences. Very few. There were hospital programs. There were technical schools and stuff. And I went to a technical school that was a 2-year program, 1 year of intensive study, and then 1 year internship. And this was before I got drafted into the military, called Gradwell in St. Louis. And Dr. R.B.H. Gradwell was the founder of the school, and he was also considered the first forensic pathologist. He was the person that developed the test to show the difference, but a precipitin test to show the difference between animal and human blood. He also was one of the first people that worked on tests for syphilis, and he was related to his niece was the daughter of Wiener Landsteiner ABO groups.
Oh, yeah.
You know, we had, some of our lecturers were Stanley Reitman and Sam Frankel are the guys who discovered transaminase units. So it was really a good school. And I was able to build on that. And then I went into the military and they said, oh, you're already a tech. Hey, you want to teach micro? Sure. You know, what's in it for me? And they go, well, a controlled tour for 1.5 years. You won't have to go to Vietnam. I said, I'm in. You know, so as it was, fortunately or unfortunately, looking back, I have some veterans guilt for not going there. I was in from 66 through 69, but I trained the people who I trained Green Beret field medics and Army lab techs and Army lab officers in microbiology. And when I got out, I got into veterinary pharmacology research, went back to school, got my bachelor's. And while I was in school, I wound up being the lab supervisor where all of this occurred after I gotten my bachelor's and master's degrees. So it worked out pretty good as it is later on in my career. I sent you my CV. I won't go into that, but you can see I managed to build on those basic blocks, turning a pretty good career, and I thought I made a difference. And if I can mention, I write a blog called Clot Club for Dia Pharma Inc., and it's got all kinds of topics that you can look at. I've probably got about 20 different articles in there, including the one on Genene and the overdose of the Quaid twins that I think we discussed last time. New ways of ridding direct oral anticoagulants out of patient samples so they won't interfere with the coagulation testing. New ways of monitoring people who are on the new gene therapy type of drugs for treating people with hemophilia, the new testing for that. And even things like factor 13 issues, Adams TS13, new ways of monitoring von Willebrand's disease. So all that stuff's on there. You can just go on and pick and choose what you want.
I see.
So, yeah. Any other questions, guys?
I'd certainly encourage everyone to go and check out the blog. Lots of interesting posts on there. And yes, the CV was pretty impressive. First time I saw a 28-page CV, I think it was 28 pages. I can get half of that, I think I'm good. But I wanted to ask, how did you get into MedLab? Was it your first choice or?
Actually, I probably, if I would have been a little bit happier with the situation, I might have wound up a athletic coach and a history teacher. But when I was a kid, I had some neighbors who had like 20 chemistry sets in their basement. And I loved to go over there and do experiments of all kinds. We actually almost blew up half their house one time. But, we tried all kinds of things. And I kept begging my parents, hey, for Christmas, give me a chemistry set. Oh, you'll just make a mess. And I really love sports and stuff. And I thought about trying to play a low level of American football. And when I looked at it, I said, I played for fun. These guys, this is way too serious. If a guy got hurt on this team, they wouldn't even let you go to the hospital to visit him. So I said, I need another option. And a friend of mine talked about the school. And when I heard about it, I thought, wow, this is something I wanted to do all my life, Anyway, so went to this school in St. Louis, Gradwell, and got really into it, did a year's internship in a small town in Illinois that actually serviced about a 50-mile area around there where there were no other hospitals. I actually learned back then, we're cross-trained in X-ray. We were the guys that did the EKGs and something called basal metabolic rates, which have been replaced by thyroid function assays now. And so I got a really good, had to go up and draw all the blood, got to work as a generalist in everything. Micro was something that was one of my favorites in school, but hematology seemed to keep drawing me in. And I was approached by a physician named Dr. Milka Montiel, who was the first woman who was ever a full professor at the University of Texas Medical School in San Antonio. She was Bulgarian, and she broke out behind the Iron Curtain with her husband. She had seen me working, and she said, I am setting up this special coagulation lab. Would you like to come to work for me at the med school? And I go, I'm in. Med school paid me, number one, and I had observed her. I liked her a lot because she came in and took over the blood bank and hematology, and she replaced 4 men who weren't doing that good of a job and did a better job than many of them, And so that's how I kind of got to it. And then coag for me was like, wow, this is this really cool puzzle. And you look for instead of trying to put it together, you look for the missing piece that's causing the problem. And I was encouraged there, and especially the clinical side that I got to see. And one thing that I found out in my position, a lot of times laboratorians, the doctors come in and say, you're going to do this. I was in the position where, hey, man, how can you help me? Particularly when I worked for the military. It was these guys were like, we don't know what we're doing here. Hey, can you give us some advice? And and with me, somebody asked me, said, where do you get your research ideas? I said, the first one that I got was the best example I can tell you. I had these people calling me, hey, I need a factor VIII level done, and it was left in the refrigerator overnight, or it was left out, and can we still get a factor VIII on it? Well, I got to looking, and the only information on storage of samples was for blood bankers. There wasn't anything for the coag lab, really. So we, I set up a small study where I ran things that were kept at room temperature at 2 to 8 degrees in a regular refrigerator, -20, -70. And we found that in a week's time, 5 days' time, you could lose 50% of your thermal label factors with factor V and factor VIII. At -70, everything stayed the same. You didn't lose any activity. So that, and then my master's thesis came about was I was working with baboons that were smoking baboons, and I was doing the coagulation, the platelet function on them and everything. And we also wanted to bring antithrombin 3 at the time it was called. It's just called antithrombin, but some people still call it AT3s. But we were trying to develop a technique, and it was a tilt tube at the time. And I was practicing with it and doing all kinds of things with the incubations and stuff. I ran out of human plasma. And I started using my leftover baboon stuff, and I found out that baboons had decreased antithrombin 3s, and it didn't make any sense because they never had thrombotic issues because what later we found out is because their platelets aren't nearly as sticky as human. In fact, if you do platelet aggregations on them, epinephrine doesn't work, and their collagen lag phase is about 300 seconds versus 25 to 60 in a human. So all of these things just kind of led one thing into another. And some of the stuff I got where people came right to me, but a lot of the research that I've done was had this idea after seeing something, and I wanted to go back and say, okay, let's take a look at this again and let's set it up. A lot of the stuff that I did was method validations for FDA approval, 510K work for companies. A company would come to us and say, hey, I've got this reagent instrument combination. What can I do to, can you shake it down to see if there's any issues? And I found all kinds of things. One company, in fact, I said, you've got a problem here. And they said, why is that? And I said, you're having a layering technique and it's causing a difference in the coagulation test that should be done. And what I found out was they had only used control plasmas instead of regular human plasmas. And the viscosity of those treated control plasmas was so different that it wasn't causing that it caused a different type of effect. It mixed very well, but their other ones didn't mix at all. One thing I found that one of the papers, I think, Wisdom, that I sent you was, you guys, was the one on the chromogenic factor 10 assay for monitoring people on Coumadin.
Yeah.
If you look at that, in there is a curve that shows that an INR above 4 is totally inaccurate and should be reported out as such and repeated. And because what happens is the INR curve actually flattens out, kind of like I equate it to like a Nike swoop. And you might have a guy out here with a factor 10 level of 12 that is has an INR that might be in the therapeutic range of somebody who's has an artificial heart valve of 2.5 to 3.5. And it also explained, there was one system that was out years ago, MLA had instruments all over the place. And I found that, again, their INRs were, we were looking at helping the pulmonologist establish a technique, a cryo technique for doing pulmonary biopsies, because they saw that about 2/3 of their patients were on Coumadin. And if you mess up the lung taking a biopsy, you got a real problem. And so it was really cool. We were using Yucatan miniature swine as the model, and I was trying to get them to a 2.5 to 3.5 level in the therapeutic range. And all of a sudden they would shoot to 8 to 12 to 18 to 31, the INRs. I couldn't figure out what was happening. I went to instead of using a photo optic system, I went to a mechanical point system. And all of a sudden the INRs started coming back normal. And this explained why some people who had this photo optic system goes, oh, this explains why we give vitamin K to these people and then they thrombose. It wasn't really that high, was it? No, it wasn't. And like I said, with that curve flattening out, it made the, at 4, it made those INR levels after that suspect. So research never really finds an answer. It just leads to other questions, is what I like to say.
Mm-hmm. Yeah. Well, that's a perfect place, I think, to wrap up.
Let's chop it up.
Yeah.
Hey,
I mean,
if anyone has any questions, tell them to get in touch with me, and I will be glad to answer them, especially in the coag area. It's really, like I said, my primary thing.
Yeah.
And I really enjoyed this. Enjoyed meeting you guys. Stay in touch. I will send you that picture of the laboratory creed.
Yeah. How do they get in contact with you?
They can get in contact with me by my email.
Right.
Dave McClassen at hotmail.com is probably the easiest way.
Okay.
If they're in the States, of course, they can, get it by a phone call. And you got my numbers on the CV for that. But the easiest way would be text, or you could get, like you've been doing by Facebook Messenger.
Yeah.
Something like that.
Facebook, LinkedIn.
Right.
Yeah.
Any of those, on all those. And appreciate you guys having me on. I've really enjoyed it.
Thanks a lot.
Meeting everybody. And if there's anything else that I can help you with, man, don't hesitate to call, okay?
No problem.
No
Thanks
problem.
a lot for coming on. I mean, we learned a lot, so.
All right.
Thanks.
We'll catch you all later.
All right.
Have a good one.
Have a good day.
Thank you very much.
Take care.
You're welcome. Bye-bye.
All right.